My name is Frank Lynch. I'm the advanced nurse practitioner in dual diagnosis, more akin to Dr. Evan Keane this morning's lecture. But I'd like to extend my thanks to TFI and their international colleagues who visited yesterday and all the support they've been giving us over the last couple of years. Just a brief outlook of what the National Forensic Mental Health Service is, and then we'll just talk about the actual smoke-free incentive that we were successful at in 2020. So the National Forensic Mental Health Service provides forensic mental health care for patients within the Republic of Ireland. It is an integral part of the HSE's mental health services for Ireland, and an inpatient is located at the Central Mental Hospital in Portrane, County Dublin. You might have noticed that we have moved from our 130-year-old building in Dundrum, which is now vacant. If anybody's looking for real estate, go down there. But we got our state-of-the-art service up in Portrane on the old St. Ita's site at the moment. So the National Forensic Mental Health Service provides high specialist services which are fully compliant with the HSE values, goals and policies and procedures within national programmes in mental health. Obviously aligns ourselves with TFI and the strategy to make Ireland tobacco free. Our service provides mental health treatment for patients who are referred to a designated centre when the courts have decided that they are unfit to trial or stand trial, or they've been found guilty of an offence by reasons of insanity. Although our community in-reach teams in the prisons, that's what we call our community psychiatric teams, we call them the in-reach teams, the National Forensic Mental Health Service provides mental health assessments and treatment to prisoners who may be also suffering from mental health disorders. The HSE's Healthy Ireland and Healthy Services Information Plan, the National Mental Health Policy Sharing a Vision, and the Tobacco Free Ireland Programme Implementation Plan have prioritised smoking cessation incentives which tackle a better Ireland, healthier Ireland and equality in healthcare. These are actually updated since I actually introduced the Tobacco Free Campus. Tobacco Free Campus in our service launched in 2020. So it was the previous documents that actually guided our policy at the time. The introduction of the tobacco dependency treatment into routine care is one of the many resources helping to address these healthcare inequalities. Although smoking rates amongst general population continue to fall, as highlighted this morning with my colleagues, they remain disproportionately high among people who have lived experience of mental health challenges. Individuals with schizophrenia and other serious mental health disorders lose between 50 and 25 years of the normal life expectancy. They are twice as likely to develop a serious mental health condition before the age of 55, and are significantly more likely to die within 5 years of that diagnosis. One of the principal reasons for poor physical health among people who have serious mental health disorder is high prevalence rates of smoking. Up to 70% of current inpatient psychiatric patients smoking, or half of these smoke quite heavily. People with serious mental health disorder smoke more, smoke deeper, they smoke longer, and they obviously affects their physical health. And that's the rationale for the reduction in mortality rates among this cohort of individuals. A report published in Northern Ireland by the Institute of Public Health has stated that among the people with the possible psychiatric disorder in Northern Ireland, most have smoked at some time in their lives, 60%, and a third have smoked. Most want to stop smoking and have tried at least once in the past. This is a snapshot of our profile of the service prior to implementation of the Tobacco Free Campus back in 2019. Overall, half the patients inside in the Central Mental Hospital, 109 patients altogether, roughly about 52 individuals had smoked for a considerable period of time. Obviously, the percentage among staff was actually quite lower, but it was still 23% of all staff within the service, of over 500 staff smoked at the time. This is prior to the incentive. The framework that we used to underpin our approach was essentially taken from how to implement a smoke-free campus. You know, it is what it is, what it says on the tin. Together with the Global Network for Tobacco-Free Healthcare Services self-auditing tool, we used these two documents as the preliminary documents to start to implement our actually smoke-free policy. Just to highlight that the pattern or the strategy that how to implement a smoke-free campus document highlights that an effective smoke-free program has a particular process, and that process is essentially communication, education, tobacco cessation support, maintaining tobacco-free environment, healthy workplace, community engagement and evaluation. So that's essentially what underpinned our approach within the service itself. So as the lead in the dual diagnosis programs within the service itself, it was kind of my duty to put together a team, and joining the TFI on different workshops and conversation cafes and reading the literature and talking to a number of colleagues around the country and internationally. We recognised that it should be an MDT approach to deliver this incentive. It can't just be an independent discipline or a siloing of disciplines. It needs to be a collaborative approach. And essentially it needs to be a collaborative approach. It needs to have a co-produced element to it, where the patients themselves are involved in the process from the very get-go. So it wasn't essentially a tokenistic approach. The patients that were inpatients at the time weren't just there to be, to be saying that we've got patients on our group. They were there actively doing work to help to deliver an idiosyncratic approach to delivering tobacco-free campus. So as you can see there, we had a dual diagnosis lead, which was myself. And it was important for those who are going to be delivering this, that it was important that we had a direct communication line to the executive clinical decision making of the service itself. So we had a director of nursing who was able to, liaise and communicate with executive managers of the service itself. So when we were making the decisions, that was brought to the senior management team very quickly, and communication was shortened. And we also had a senior medical registrar, which was very important because we needed someone to be involved in prescribing of the NRT. Although I am a nurse prescriber myself, and there is nurse prescribers in the service, what we required was the medical backing, because doctors would be prescribing a whole range of medications, and the NRT was essentially part of their remit to do so. So it was very important to have registers, and it's very important also to have social workers and occupational therapists, because we all know what impact smoking has on a person's occupational health, and also how the impact it also has on their social well-being. As I already mentioned, we already had 2 patients on our steering committee, and that was important for them to get the lived experience. These are people who were smokers and essentially were against the smoking cessation policy itself. The aim was to get their lived experience, their narrative of what they felt was good in their environment, and not something that was going to be like a top-down or authoritarian discipline approach. It needed to be designed by themselves. We also had a patient advocacy representative, so it wasn't just these 2 patients' a perspective, but it was also representative of the entire group as well. In the initial stages, following the guidance from the TFI document, the initial stages was gathering of information and disseminating as much information as we possibly could on the pending tobacco-free campus. We essentially littered the place full of information, leaflets. We did a number of audits, a number of surveys. We did as I mentioned, we had patients who did peer-to-peer groups themselves, who gathered as much information, and that content was actually the driving, or was the fuel behind the rest of the processes. Was the fuel behind how we wrote our policies, was the fuel behind how we designed the clinical approach, and essentially is how we effectively delivered the program itself. These are the number of responses we would have got from both patients and staff prior to delivering of the incentive. And as you can imagine, I was a very disliked individual for a period of time in the hospital, more so than usual. Some of the quotes was, "You're infringing on my human rights. How am I going to get to reduce my anxiety? It helps me sleep. This will never happen. Can we smoke and leave from? Can we smoke if we go and leave from the hospital, as in community leave? Can we get e-cigarettes? I'm going to sue the hospital." It was also a very big topic at that time. But it wasn't as bad as the backlash I got from the staff itself. The patients were actually more friendlier, and the staff said it'll never happen, you're going to cause a riot. What about staff who smoke? Where are they going to go? And are we going to get compensation? Is the big one within the HSE. Do you provide nicotine replacement therapy? And at the time, there was no NRT available for the staff. We had to go through occupational health at that time. And how do I get an occupational health assessment? We were armed then with the information from TFI, the international, recognised valid and reliable information from our own colleagues in forensic facilities in the UK and Australia. We had talked to a number of CHOs and voluntary and non-voluntary organisations throughout Ireland itself. So we were armed with a lot of answers to a lot of questions. So it is time to put it into action then. So what we decided to do was to divide the working group into 3 distinct groups, where I was the link between the 3 groups, and I would link that up into the area management team. So the idea was that we would identify the experiences by the person in the group itself. So the policy group was essentially to design the Tobacco-Free Campus National Forensic Mental Health Service policy. As I already mentioned, we gathered a lot of information in the surveys, we got a lot of information in the peer-to-peer, and that was what populated the policy itself. Obviously, it was in line and in parallel with the evidence-based that we were learning from the workshops and the TFI themselves. The second group was the clinical group, and I suppose this is the kind of concern, this is the issue where most of the services I've been talking to, the mental health services, that smoking cessation is a multifaceted concern. It's not just we're going to stop smoking, and it has a multitude of different threads to it. So our prime aim for the clinical group was to solely focus on what intervention could we give to the patient at that time. And we have to remember as well, this is an inpatient acute hospital, so we had a variety of different levels of wellness from admission to discharge. We have 109 patients, and 50 odd of them were smokers. Some of them were very well mentally, but some of them were very unwell mentally. So we had to figure out what was the best approach for those individuals at that time, because not all one intervention suits one person. We're all different at the end of the day. So we had to design an approach, and that was in line with the TFI and the training that Elaine and the team provided. It was essential to drive the best supports for the patients going forward. So the third group was the NRT group, and the NRT group was the nicotine replacement therapy group. And being a forensic service, we had to risk assess all available NRT and what that particular product what risks it did actually maintain for an environment that we were in. So we ended up reviewing and risking all the available products on the market, and we ended up with obviously aligning ourselves with the best practice, which was short-term, long-term behavioural support. So we ended up with the patch and the plastic pipe as the only methods of NRT available to us at the time. So it was important to review all that and risk that. And to date, learning curve. So I could successfully say that we were implemented the Tobacco-Free Campus on the 1st of February in 2020. Just coincided with the emergence of the COVID pandemic at the time, and unfortunately, but fortunately as well, there was a lot more positivity in people's physical health, and we felt that we got just an extra rise or an extra bump off that. The transition from the smoke to a smoke-free campus was viewed as a very seamless process for those who weren't involved in the process itself. However, the steering group were all agreed that a continual delivery, evaluation, and synthesizing of the information that focused on the uniqueness of our demographic was the key component of this successful incentive. What I essentially mean there is that we utilised the information that was available to us and the resources available to us via TFI, via our colleagues, and parallel information, clinical information. We got our idiosyncratic opinion and knowledge from our patients and from our own group, and we merged them together. We didn't try to force a square block into a round hole. We carefully moulded it to fit into exactly what was required. And we were quite conscious of that because this was the 4th attempt of the service to really try to bring in this. As you can imagine, it's quite difficult within our cohort, but we learned from our mistakes and we realised that we needed to design these programs in accordance to our setting. So I'm not going to sit here and say that we are a tobacco-free campus. I mean, there's no smoking areas and there's no exemption. There's no staff or patients smoking within the areas whatsoever. But we're not beyond doubt that there hasn't been some limitations within the policy itself. Look, in the early stages of the policy, there was some breaches in it, and the breaches were based on miscommunications between contractors coming into the service or family members coming into the services. Alternatively, we should have done a little bit more in the proactive element of when patients get discharged into the community. Unfortunately, 2 of our clients had relapsed because they were smokers. They went back out into the community and they were on antipsychotic medications. And for those who are just not up to speed in that, like if your titration, your serum levels will drop on antipsychotic medications if you are a smoker. So essentially, the individuals weren't getting a therapeutic dose, and then the relapse, and not a full relapse, but a lapse that would cause a recall into the service. So it's quite an importance that although the individuals may have been in a smoke-free environment for a few years, there was still a risk that the individuals could relapse. So this is kind of the most important key element really in the tobacco-free campus in relation to a mental health facility, is that it does affect their psychiatric medication, it does drop their serum levels and can cause a lapse and can cause a relapse. You know, smoking can reduce their finances, can lead them to go into black market buying of cigarettes and so on and so forth, and can lead them to high-risk situations. These people are quite vulnerable when they are unwell. So essentially, cigarettes in our cohort can cause a serious risk, and that's me, I think. Thank you.